So the insight of purposeless function is going to require an understanding of purposeful function to see what really is supposed to be happening when it's happening. So we can back out of it and say, you know, that other stuff that's kind of weird. We need to address that. Let's take a look at normal. This guy's in rest position. He closes. We've got the medial pole at its highest position. We'll call that CR, centric relation. I didn't put any muscles on this diagram. That should look weird. Like, how the heck did he get that jaw to elevate like that? So I always imagine there's a muscle in there occluding. This is an occluding scheme right now. And our occluding scheme is allowing for providing where the condyle is at its most superior position in that fossa. We're going to call it CR. But I don't want that arrow in my way for now. This joint it's really two joints. There's the superior side of this disc that articulates against the eminence. There's the superior side of that joint, and this inferior side was the condyle and the inferior side of the disc. There's two separate joints there. They both do completely different things. If we wanted pure translation, where the lateral pterygoid is contracting all by itself, if you start with the condyle at its highest spot up that eminence, braced in that centered position at CR, and all you wanted was lateral pterygoid contraction activity, the condyle comes down out of CR and all of the teeth will disclude. That's just the nature of the slope of the eminence. And that's really why we use CR. We're trying to disclude teeth in the event someone slows down on their clenching intensity. Had nothing to do with mastication. CR, when they say CR in our functional occlusion, no, we're using CR to address parafunctional occluding, because once someone's up in CR, we need to get the posterior teeth discluded as soon as we can. We saw how bad it is if you have a unilateral posterior contact. The posterior contacts allow the most muscle contraction intensity. If they're going to be occluding, I hope it's not the posteriors that are doing so. Coming down out of CR is the first line of defense in traditional occlusal therapy to disclude molars. So when someone says, when you try to seat someone to CR, you find the interference to CR. The condyle can't get to CR because there's a palatal cusp banging on a distal buccal cusp of a lower molar before you can get to CR. We're trying to find those things because that same interference to CR is the first contact coming down out of CR. They lean on that one posterior contact and you have joint strain on the other side. So Pete Dawson, who I adore, says, look, we need to get them to CR first. And then when they're coming down out of CR, you can't get joint pain because there's no posterior interference, no posterior contacts. We'll show that in a second. Let's look at the positional range of purposeful masticatory function. So the translation side of this disc is commensurate with the anterior-posterior position of the incisors. We're going to incise on something here. The inferior side has to do with rotation. The rotation of the condyle is commensurate with how the vertical dimension of the bolus that you're about to engage. How far forward do you have to go? How far open do you have to go? So this degree of translation from that red arrow to here is represented. The black arrow is this black line. That's how far translated the condyle needed to go to get incisor over incisor for incisor. You don't need to go farther than that. So we put a bolus in here. The vertical dimension of the bolus dictates how much rotation of the condyle needed to occur to accommodate for this bolus. Now, is this bolus going to be a frozen grape or a regular grape? With incisal edge contact, we're only going to get 30% of maximum clenching voltage. So that's kind of okay. Hey, that's in that incisal contact. However, even with 30% contraction, if the condyle is overly rotated, when there's incisal edge contact, you get joint pain. Nobody bites on something hard with their teeth that far apart. We all know it. It needs to get a little bit smaller before your teeth can like bite it. It hurts up here. That's how the system works. Overly rotated condyle, too much vertical dimension of the bolus will cause joint strain during the occluding act, even though you're only at 30% of maximum. If you could just make that thing smaller, you're okay. You'll get 30%. So the number 2 most common reason why an NTI fails, they're too big. Too much vertical dimension of occluding. You've over-rotated the condyle during a closing event on the object. So as you go through, I made this GIF a while back for a purposeful function, but the farther back the bolus gets, the closer the molars are getting and the more compression, the more crushing that the system is capable of. And as the intensity increases, it's only when the bolus is at its farthest back position and the joint is the least translated and the least rotated. So normal crushing of food, when it gets to your back molars, their molars aren't very far apart. When you go to crush the most, the joint is the most seated and braced. The opposite, if you provide something that allows them to clench with their condyle overly translated or worse, overly rotated, you're going to get problems. You're not going to understand why this patient doesn't feel better. Why does it hurt? I made a splint. Why does it still hurt? It could be the dimension of your splint, or it could be where they go on the splint.